You
So,
log out of the other device because there will be echo in the other
Just
device.
what I am doing that.
Yeah.
तो मैम जो मैं कह रहा था ना अनिता मैम, तो ना हम लोग क्या कर रहे हैं, इसलिए पैनलिस्ट बीच में रोक रोक कर क्वेश्चन पूछ रहे हैं ताकि
Okay.
डिस्कशन एटलीस्ट गोज टू द ऑडियंस।
I
Right,
see.
right.
तो
Okay.
1 घंटे का
Okay.
सेशन में बोर हो जाते हैं अदरवाइज लोग।
So we can sort of discuss some important questions if required
यस मैम,
while the presentation is going
यस
on. Okay.
यस,
All right.
दैट वुड बी, दैट इज ओनली वे आउट बिकॉज ऑडियंस को
Correct.
ज्यादा कर नहीं पा
I
रहे
think
हैं।
the quorum is complete. Dr. Manjari is also joined.
ओके, डॉक्टर मिश्रा, समिता मिश्रा ने हैंड रेज किया है, जस्ट एक बार पूछ लीजिए क्या कह रहे हैं।
So can I start now?
यस
Yes,
Yeah, we start.
Dr.
Yeah,
Snehal, I think we'll just introduce you if it is okay with Dr. Neeraj.
yeah.
यस मैम, यस।
Okay, so first of all, thanks to Dr. Neeraj Agarwal and the team for having these sessions. I think they are very, very useful for the
Pediatric.
pediatricians and pediatric cardiologists, I would say. And Dr. Snehal Kulkarni, I think, is well known to the community. She's of course, a very renowned pediatric cardiologist, currently serving at Fortis Hospital, Mumbai. And I think as a president of Pediatric Cardiac Society of India, she had taken very, very important steps in furthering the branch of pediatric cardiology and bringing it to pediatricians, and as well as going on for super specialization courses like intensive care, fetal echo, and so on. And I think one of our passion is to ensure that we have some pediatric EP in our country, something that we don't have as of now. And this is becoming a real big problem, not just for pediatricians, but even for us pediatric cardiologists, because we are seeing lots and lots of post-operative cases coming with sometimes very refractory arrhythmias. So today's, I think Dr. Neeraj has two sessions, one on TECI and one on Brady. And today's session is on bradyarrhythmias, which Dr. Snehal Kulkarni will talk about. Please feel free to ask questions in between so that we have a live discussion. And Dr. Snehal, I hope you won't mind panelists sort of discussing it in between your presentation if there are some important issues to be discussed. So over to you, Dr. Snehal Kulkarni.
I'm like 1 second for president of Dr. Pankaj would like to say something.
Sure.
Good morning, all the panelists and the speaker, Dr. Praveen Gokhale sir, Dr. Anita Saxena madam, Dr. Manjari Agarwal, and of course the speaker, Dr. Snehal Kulkarni. IAP Delhi at its academic form has been doing these e-master classes in various specialties, and this time we are doing pediatric cardiology, and we are getting very good response, not only from the people who attend, but the panelists also, they join the other sessions as well. So we'll keep on working in this field, the academic activities of IAP Delhi, and we look forward to a very interesting discussion today also. So I request Dr. Neeraj to start the proceedings. And we can, Dr. Sham is also there. We request Dr. Sham to say a few words, please.
Hey, good morning to all. Very warm welcome on behalf of Delhi IEP to all today's speaker, Dr. Snehal, and our chairperson, Anita ma'am, Dr. Pramod, and all teams. And I would like to again thanks to this program chief coordinator, Dr. Neeraj. You are doing the wonderful job, and I hope you continue the work with the IEP in future. And best wishes to all participants. Over to Dr. Neeraj.
Thank you, sir. So I have to request you to get some time for the introduction of chairpersons also. Saxena ma'am has kindly agreed for chairing the session today. You know, when ma'am Saxena Kulkarni's name was given to lecture, I thought who can chair the ma'am. So there's no one else than Saxena ma'am. She has been the uh, doyen of pediatric cardiology from India. She motivated all of us, including me, to join the pediatric cardiology. In 2005, I joined her, and I am her student also. And she has been vice chancellor of Rohtak University recently, and she has joined Fortis as course recently. Ma'am, thank you for allowing this session and chairing this session. We always welcome you in our all the programs, and your words are very, very valuable to us. Thank you, ma'am, for joining this session. Then we have our EB member today, Dr. Praveen sir. In spite of his busy schedule, he has agreed us to chair the session. He has a clinic in Thane, and he has been president of Thane Academy of Pediatrics. He is vice president of Maharashtra State IAP, and he has special interest in critical care. That's why we thought to include him in today's session. He has been investigator for vaccine trials also. He has a lot of interest in vaccine and intensive care. We welcome you, Dr. Praveen sir. Thank you for joining us today from your busy schedule.
Thanks a lot, Delhi team. Thanks a lot, Gangaram Hospital.
Thank you,
Thanks.
sir. And we will have interactive session in the class also during the class today. Please be around. And Dr. Manjari, she is our pediatric rheumatologist from Gangaram. She has grown with us. When I joined Gangaram, she was joined after some time, and she has been our chief pediatric rheumatologist to go about. She has special interest in SLE. That's why we thought let her include her. A lot of bradyarrhythmias have SLE component. So we thought let's her have her input also. Dr. Manjari ma'am, thank you for joining us. And Dr. Manjari, are you around?
It's an honor, sir, to be here. Thank you.
Thank you. So a lot of pediatricians and pediatric cardiologists are in the background. They will all listen to you today. And now we respected Dr. SNEHAL KULKARNI ma'am. You can start the session. Thank you, ma'am, to start the session.
Thank you, Neeraj, for inviting me for this webinar. And thanks, Anita, for this kind information. And we all are working really to get all the pediatricians with us to sort out our simple common problems. So just see how to approach pediatric bradyarrhythmias from the pediatrician's perspective, actually. As we know, heart rate is an integral part of clinical assessment. It's commonly used as an early warning sign, either too low or too high. We know that there are age-related changes which produce normal range for different ages. We know that for neonates, we really have very high rates. As the children grow over the period of time, the heart rate keeps on coming down. And this is a normal autonomic system development in children which changes their heart rates over the period of time. If we see bradycardia, it's defined as a heart rate which is below the normal value for that particular age. It may be even a sign of healthy athletes. As you know, some of the athletes, the best known figure is, Bjorn Borg. He was a very famous tennis player. And his heart rate used to be almost 30 to 35 over that period of time. And in athletes, because your stroke volume is very high, your heart rate comes down. So it's a sign of healthy athletes. But on the other side, it can be a sign of serious conduction tissue disorders. So it has to be taken in that particular clinical perspective when we try to see the heart rate in any normal child. So by definition, bradycardia is a heart rate that is slow in comparison with normal heart rate range for the particular age of the child and the level of the activity. So both the things we have to take into account when we see heart rate in a child. We have to see what is the age of the child and what is the level of activity. If the child is running fast, many times we see that in the clinics, the heart rates are very high. But if you see in the sleeping time, the heart rates can be very low. So, and on the other side, bradycardia can be an ominous sign as well. So when we talk about the bradycardia or bradyarrhythmias in children, we have to describe when bradycardia requires immediate interventions, or it can be just a normal phenomenon in a child. Describe initial step to stabilize a child with cardiopulmonary compromise in extreme cases. Know when to start CPR in a child with bradycardia. Manage the child as outlined as pediatric bradyarrhythmias with your pulse guidelines and select appropriate medications. And these are some of the objectives when we, for discussion, when we really have a child with serious bradycardia. So sometimes the bradycardia can turn into cardiopulmonary compromise with hypotension, decreased level of consciousness, shock, poor end organ perfusion, respiratory distress, and collapse. When we see a child with bradycardia, there are two types of bradycardia. One is a primary bradycardia. That is it's related to the cardiac problem. So really there is a problem with the conduction tissue and the child can have bradycardia. Or we can have secondary bradycardia. So actually the heart is normal, but we have some other causes which may be responsible for causing bradycardia. The second thing, what is very important, is a complete heart block related bradycardia. So it's usually cardiac origin. It can be congenital complete heart block causing bradycardia, long QT syndromes, sometimes some post-cardiac surgical repairs, mainly when the surgery is done around the conduction systems. From the immunological point of view, if the mother has a history of lupus, the child can have bradycardia because of complete heart blocks. Some of the infections can cause bradycardia, especially myocarditis, endocarditis, some of the rare diseases like Lyme disease, Previously, diphtheria used to be a cause, but we don't see diphtheria often. Acute rheumatic fever with carditis can cause bradycardia. Some of the metabolic diseases like glycogen storage disease, carnitine deficiencies can cause bradycardia. And some muscular dystrophies, when they are associated with cardiomyopathies, they may present like bradycardia. So what is the etiology of sinus bradycardia? Sometimes we'll come for cardiac issues later, but the other non-cardiac causes of sinus bradycardia is respiratory. Severe hypoxia, apnea bradycardia of prematurity. Some of the neurocardiogenic problems like increased vagal tone in a child. Situational, even sometimes coughing, breath holding, deep sleep, it can cause bradycardia in a child. Neurological problems like increased intracranial tension, always child who comes with stroke with increased intracranial tension can have bradycardia. Hypothyroidism is a very common cause of bradycardia in anybody in general. Some of the drugs like beta blockers, fentanyl, they can cause a reduced heart rate in a child. And some of the electrolyte imbalance, actually this is a very, very important cause of bradycardia, hyperkalemia or hypercalcemia, because many times we go to the ICU and some child, especially this happens very commonly in cardiac ICU, the child's heart rate is maybe 50, 60, 70. And there is always a lot of rush. How can we treat this kind of bradycardia? And if you see, especially in cardiac ICUs, most of the children are on a lot of diuretics, and your sodium is 152 and your potassium is 2.6, and that is a cause for bradycardia. Actually, here the bradycardia doesn't need treatment. The treatment is actually correction of potassium. So these electrolyte imbalances are very, very common cause of bradycardia, especially when you see a child in intensive care units. And actually, these are kind of some of the reversible causes. And I said like hyperkalemia, hypothermia, hypoxia, some of the toxins, these are reversible causes of bradycardia. So what are the clinical features? How do we approach the child who comes to you with a heart rate of 60? The commonest cause of bradycardia in a child is sinus bradycardia. Actually, they are having this kind of a low heart rates for a long period of time. And these are some of the reasons because of autonomic system imbalances. Sinus arrhythmias are very, very common because you see varying heart rates, sometimes very high, sometimes very low when the child is regularly breathing. So sinus bradycardia, sinus arrhythmias are very, very common in child in a growing age. And usually they have no symptoms or signs. They just come to your clinic and you see the heart rate is 60 or 70, will not have any symptoms, and they will have, sometimes if extremely low heart rates, you may just follow them, but they don't have any signs or symptoms. In infants, if they have significantly low heart rates, they may have feeding difficulties, lethargies. Fatigue and exercise intolerance in children if they are especially playing, mainly because the cardiac output becomes less. Cardiac output is heart rate into stroke volume. So the stroke volume is limited and the heart rate is less. So they have something called as a low cardiac output states, and they have fatigue or exercise intolerance, which is a very common symptom of low cardiac output. Extreme bradycardias, especially in adolescents, they can have syncope or pre-syncope. And at any stage, if they have severe bradycardias with poor perfusion, they may present like shock or arrest, which at any age. Cardiac defects which are associated with bradycardias or maybe complete heart blocks. Some of the little rare cardiac problems like corrected transpositions, complete AVL septal defects. Some of the very like rare cardiac abnormalities like heterotaxy syndromes. Long QT syndrome, actually one of the first thing what you have on clinical examination is bradycardia. And some patients may develop complete heart block and bradycardias after cardiac surgeries like surgical repair of TAPVC or AV septal defects, because sometimes these surgeries are being done at the conduction system somewhere, either sinus node or AV node, and they may develop bradycardias or complete heart block. What are the red flags if you see a child with bradycardia? Which are the children who need further investigations, treatment, or need to be monitored very carefully? If you have a heart murmur or have a history of congenital heart defect with bradycardia, syncope, especially most of the syncopes have some kind of a triggers like loud noise, exercise, or extreme emotional stress. If you don't have any triggers, but child has syncope with a low heart rate, the child needs to be investigated. Other associated symptoms such as chest pain, palpitation, dyspnea. If there is a family history of sudden cardiac death, long QT syndrome, sensory neural hearing loss, we know there is a syndrome called as Jervell and Lange-Nielsen, which has a hearing loss with complete heart block. Familial heart diseases. Somebody in the family has a pacemaker implantation at an earlier age. That means there is some family history. Medications which can result in bradycardia, especially beta blockers. And as I said previously, absence of any premonitory symptoms, but has a bradycardia and syncope, they needs to be evaluated for evaluation for bradycardia. When we take a history of a child, what are the goals in the history? Basically, we have to see whether there is a symptom rhythm correlation. Means, suppose you have a significantly low heart rate, whether the child has any symptoms with that or nothing happens when the child has bradycardia. Try to identify etiology of bradycardia. Many times, as I said, it's an incidental finding in the presence of excessive vagal tone. Symptoms of feeding difficulty in infant or exercise intolerance in children. Syncope or pre-syncope with bradycardia, whether it is possible to correlate them, and any presence of symptoms attributing to arrhythmias, which are important things for the management point of view. It is common in a child is a sinus bradycardia and can be a physiological consequence of decreased metabolic demand, but sometimes very sleeping. Increased stroke volume in athletes, as I said, because the stroke volume is very high. To maintain the cardiac output is, as I say, stroke volume into heart rate. So the bradycardia is very common. And other, as I told you, other potential causes which can include hypothyroidism, neurological, beta blockers, hypothermia, sometimes infection and sepsis. By and large, sinus bradycardia is never primary in cardiac in origin. Usually it is secondary to any of these other factors or some autonomic disturbances, but it's usually the underlying cardiac structural heart is usually normal in sinus bradycardia. So it's when we assess the child with bradycardia, it's very important to find the underlying cause. Whether it is sometimes even a forceful vomiting in some children, it can cause because of the increased vagal tone again, vasovagal syncope. Factors exacerbating vasovagal syncopes like fatigue, dehydration, hypovolemia, emotional stress, reaction to pain. So usually, as I said, it's usually not related to heart. There are a lot of secondary causes with sinus bradycardia. So in the history, we try to relate symptoms with bradycardia, and this sometimes by evaluating a child with bradycardia can be very challenging. So, and somebody who has a chronically low heart rate in a child for we don't know how much period of time, and usually does not contribute to new onset of symptom because they are used to have this bradycardia for over the period of time. And we have to document whether the symptoms are related to the low heart rate. And sometimes, this smartphone technology or somebody wears Apple Watch and somebody has symptoms, it's very easy to see whether the symptoms are related to the low heart rate at that particular time. Just try to see for a family history. If anybody in the family has a pacemaker at an early age, may have a familial inherited disorder. So family screening may be important in this period of time, whether especially if you have a maternal lupus. Now, if you try to see physical examination, actually there is nothing much significant except somebody has a low heart rate with 40, 50s, 60s. May not be 40s, but maybe 50s, 60s for the particular age group. Newborn with complete heart block with maternal antibodies may have lupus rash that may give a clue that a child may have a complete heart block because there is a maternal history. Whether you have a clinical evaluation, signs of goiter because of hypothyroidism, and sometimes significant weight loss in the absence of physical disorder, I think it may suggest a reduction in the metabolic rate leading to bradycardia. When we talk about bradycardia, from where this low heart rate comes, so it's important to see what is the normal conduction system in the heart. We know that this is the sinus node from where the impulse arises. It goes to the AV node, then the His bundle, and then it goes into the right or left bundle branches. So whenever there is a bradycardia, many times either there is a problem with the sinus node because the sinus node doesn't work the way it is expected to work because the heart rate comes from there. And it has a lot of sympathetic nervous system related issues. Then when the heart rate becomes low or very high, then it goes to the AV node. There can be a problem with the AV node or His bundle. And these are the reasons why the bradycardia may happen in anybody in general. The second most important thing, when we suspect anybody having bradycardia and we take a ECG, just try to see that your paper speed is normal. So normal paper speed is 25 millimeter per second, and see that when you take a ECG, your paper speed is normal. It's not too high or too low. Then important to calculate the heart rate in the ECG. So normally I'll just simplify, just take 2 consecutive RR waves. See how many squares it has. It has now this ECG has 3 big squares. I divide 300 divided by these 3 squares is 100. So it is a very simply simplifying the calculation of the heart rate in any of the ECGs. Many times with the digital ECG, actually the heart rate comes on the ECG paper itself, but sometimes there can be a lot of disturbances. So it's important to calculate the heart rate yourself. Now see this ECG, Now, in the ECG, what you try to see, there's a significant bradycardia. Now, you see the big squares, they are 8 and above. So, 300 divided by 8, so your heart rate is around 40. So, it's a significantly low heart rate. The child has sinus bradycardia. Very important to look in the ECG that your P wave is followed by a QRS complex. And then you don't see anything in between the 2 RR intervals. So it's a P QRS followed by QRS complex, which is a narrow QRS complex. So this is a sinus bradycardia. The rhythm is sinus. It's not anything else, which is because the P followed by QRS is always a sinus rhythm and significant sinus bradycardia. This is the way we will have sinus bradycardia.
Ma'am, can we have some question here on the ECG?
Yeah, sure.
On the ECG, ma'am.
Yeah.
Lot of students we have, ma'am, Saxena ma'am is also around. Lot of students we send the ECGs to us that are we sure this is heart block? They are not 2:1, 3:1. There are a lot of confusion in the student's brain. So you have clarified, but can we revise it again for the students slowly?
Yeah, so I will show some ECGs about 2nd degree and 3rd degree heart blocks as well. But Anita, any comment on this?
Yeah, I just wanted to add one comment that sometimes when the heart rates are so slow, like you're showing here, each lead may just have 2 QRS complexes, as you can see here. Now, I would just like to rule out a 2:1 AV block because a P wave sometimes get buried into the T wave. Here it is very clearly sinus rhythm, so there is no problem. But when the rates are very slow, I think we need to rule out real blocks. So what I think I suggested most of the machines have also that there is a rhythm strip in the end, which is usually lead 2, where the P waves are best seen, as you've also shown by arrow. So very many machines will have the lowest complexes as a rhythm strip, which is a continuous strip and does not get stopped after 2 or 3 beats. So that really helps us to know whether it is sinus brady, sinus arrhythmia, or any other kind of block. That's all I wanted to say.
And second question is, how many times practically you have seen sinus bradycardia? Like, where do you see sinus bradycardia in your practice? Like, I see in ICU. Most of the time, I see in ICU with the CNS issues, the sick patients. I see bradycardia, and I called for the bradycardia in those cases. And then, do I intervene for the bradycardia in the ICU? Like, suppose the heart rate goes 20, 10. When do I put a cutoff to intervene in a sinus bradycardia?
So as I said that in a walking normal child, I will show you some of the strips also. The child had a 50 heart rate. I was worried why it is. The child is absolutely normal. So many times what I feel that you have to correlate the symptoms. 20 heart rate, definitely somebody will be really very sick or has some perfusion issues, and I think it will come to your past guideline to treat them. But for the particular age group, whatever heart rate you have, it is really less than that. We need to investigate actually. And how do we investigate? I'll just come to that also. But as Dr. Anita said, it's very important to have a long lead 2 to really be very sure that it's a sinus bradycardia.
I think in a child who's up and about and still just has a heart rate of 40, 50, you could just make him walk or even run, and the heart rate should come back. Should increase. So that will be a good sign. But of course, if the child is in ICU or the baby is in ICU, then you have to think of things that Dr. Snehal has already talked about.
Yeah, and I think this electrolyte imbalances are very, very common in our cardiac ICUs, and they need to be really looked into carefully.
Yes, ma'am.
Usually sinus bradycardia is decreased automaticity of the sinus node. So normal ECG features is a sinus rhythm, P wave morphology, C for PR interval, QTC interval. Sinus rhythm with a heart rate below normal levels, we just need to look. Mostly they are asymptomatic with no much clinical relevance. So try to see for underlying causes like in neurological patient, increase intracranial pressures, drug overdose, hypothyroidism, congenital central hypoventilation syndrome, athletic conditioning, long QT syndrome, and sometimes eating disorders. Management option manage actually the underlying cause because most of the time the heart is normal. Temporary pacing is rarely needed. Is required when bradycardia, as you asked Neeraj, requires when bradycardia is severe and treatment of underlying causes we could not resolve that. Sinus bradycardia in the newborn usually is a sign of underlying long QT syndrome and maybe 2:1 block, what Dr. Anita said, to really see it very carefully. Congenital central hypoventilation syndrome, sinus arrest can be potentially contributing to morbidity and mortality. And in long term, really severe sinus symptomatic bradycardia need a pacemaker. Now, this is a junctional bradycardia. Again, it's a bradycardia, narrow QRS complex. But carefully, if you see, your QRS is not preceded by a P wave. So it's again a bradycardia. You don't see any other abnormal P waves in between. But it actually just behaves like a sinus bradycardia. Here, the sinus node is a problem. So the other automatic the sympathetic activities or the nodes which take over, and it is responsible for junctional bradycardia, should be treated as sinus bradycardia. And these are called as a backup pacemakers. It's not a sinus node, but other node into the atrium takes this activity, and the rhythm is maintained. It's a low automaticity of sinus node, absence, abnormal P waves, and narrow QRS complex. Now comes to the first degree heart block, as you are talking about. Here, again, what we see, it's a sinus rhythm because every QRS is preceded by a P wave. But what is happening? The PR interval is prolonged. So they are normal again PR intervals for particular ages. So this is again a part of a sinus bradycardia, does not require treatment. Just find out what is the cause for prolonged PR interval. So you see the P and R, the PR interval is prolonged. Again, the QRS complex is quite narrow. So this is called as a first degree heart block. Again, I'm just showing P and QRS, this QRS complex. So usually it is a AV nodal disease, sometimes even with increased vagal tone, myocarditis, electrolyte imbalances, drugs like beta blockers, they may be responsible for first degree heart block. So it is just, it's a sinus rhythm, but a first degree heart block. So it is secondary to the decreased conduction velocity at AV node due to increased vagal tone. Again, all the ECG features are completely common as sinus rhythm, except prolonged PR interval. So normal PR intervals in infant is less than 120 milliseconds, and in the elderly children or in adults, it's usually it is less than 200 milliseconds. So anything above 200 milliseconds is absolutely abnormal, and it's called as a first degree heart block. Usually it may not cause bradycardia and is not precursor for complete heart block. So usually does not need any treatment. Now, if you come to second degree heart block, there are two types. One is Mobitz type 1 and Mobitz type 2. So what happens in Mobitz type 1? There is a gradual prolongation of PR interval. You see this PR interval, this PR interval, this PR interval. At the end, the QRS complex is dropped because the PR interval is prolonged. So this is called as a Mobitz type 1. And diagrammatically, if you see this is a P wave, this is a P wave, this is a P wave. So there is a gradual prolongation of PR interval, and at the end, the QRS complex is completely blocked. Again, this is a relatively benign lesion. It's a little, I'll say little severe variety of first degree heart block. In first degree heart block, the sinus rhythm rate completely is maintained. Here PR gets prolonged, and at some time the QRS complex is blocked. Is again due to block with the AV node and increased parasympathetic tone or some kind of drugs like beta blockers. And again, this is a benign rhythm and does not require any treatment. Now, the second degree heart block, type 2, that Mobitz type 2, it's a little, not a benign rhythm, it's a dangerous rhythm, because I'll just show you some of the ECGs. So now you see two P waves, one QRS complex. So what happens in second degree Mobitz type 2 heart blocks? You have a two or sometimes even two P waves, one QRS complex, two P waves, and this rhythm has a potential to generate into a third degree heart block or a complete heart block. So somebody having 2:1 or a 3:1 heart block or Mobitz type 2 heart block needs to be followed or worked up very seriously. So see, this is few secondary degree heart block. Either it is 2:1 or a 3:1. So some P waves, but not all P waves are conducted to the ventricle. PR interval can be constant and normal, can cause bradycardia, and this is one of the little dangerous rhythm which may progress to complete heart block. Now, third degree heart block. Now here you see bradycardia also, but you see your P waves and QRS complexes are not related to each other at all. And this is really one of the serious or a complex rhythm where your P waves, they are discharged on their own. The QRS comes on its own. So there is no correlation between P waves and QRS complex. So P wave comes on their own. There is no relationship between P wave and QRS complex. By and large, your atrial rates are quite high. So no connection between atria and ventricles. There is atrioventricular dissociation as far as the rhythm is concerned. Usually, the atrial rates are greater than the ventricular rate and no association between P and QRS complex. Many times they have narrow QRS complex, and this rhythm needs to be taken very seriously. It needs further evaluation, and there is a need for pacemaker in this kind of situations sometime. So this is the P waves. See this P, QRS. So this is the third degree heart block, and it can be because of multiple things. It can be congenital complete heart block, or sometimes maybe secondary to surgical repairs after with complex heart defects. Maternal lupus can cause this kind of a rhythm in the baby. So this is one of the serious rhythms, and they can be very symptomatic at time, and they need to be evaluated with proper investigations.
There is a question on the chat box about this ECG. How to differentiate third from first based on PR interval?
No. See, if I show you the first degree heart block, now it's a sinus rhythm. I'll show you the every P wave is related to, see here now, first degree heart block, every P wave and the QRS complex, they are related. So P wave conducts to QRS complex. So every QRS complex is preceded by P wave. So it never happens that your P waves are discharged independent of QRS complex. It never happens in complete heart block, third degree heart block. You see P here, you don't see a P here, or you see a P here. So this P doesn't have a QRS complex. There is a P wave, it doesn't have a QRS complex. So they are discharged independently. Usually you may see an atrial rate of 100, the ventricular rate of 40. In first degree heart block, if your atrial rate is 100, your ventricular rate is also 100. It never happens, they're independent. So every P wave has a QRS complex. So atrial rate and ventricular rate are the same. This happens in PR interval, only first degree heart block, only a PR interval is prolonged. If you see if you see here, these are the P waves, these are the QRS complex. So many times your atrial rates are very high, your ventricular rates are very low. So there is no relationship between P wave and QRS.
One more thing, ma'am, in the third degree AV block, like we have rheumatologists also available here in the chairperson. We can take their opinion also from you.
Sure.
That in third degree heart block, how much frequently you see in SLE mothers in and then newborn having heart block, then we can take some opinion from rheumatologists also.
So yeah, we do definitely take, and many times even during we do fetal echocardiographies very often, and we do see complete heart blocks, and we ask always the mothers with a history of lupus or any other rheumatoid disorder. And those babies, actually all the the mothers who have a history of rheumatoid heart disease or SLEs, there is an indication that they have to have a fetal echo scans periodically.
And recently we had a seminar on SLE mother. Manjari was in charge of that session. Dr. Manjari, are you around? Dr. Manjari? Actually, Dr. Manjari is not around. So we had this session on rheumatological disorders.
No, I'm here. I'm very much here.
Okay. Manjari, we had session some 2-3 weeks before about this SLE mothers, about this heart block. What is your opinion about this, like SLE mothers having heart block? How do you manage these patients in your practice beyond rhythm issues also? And you say something else has to be monitored in newborns beyond heart block also. Is it true for us and for the pediatricians?
Right. So if we have a SLE mother, so there are two problems. First of all, one is in a case where the mother is not a known case of SLE. Then you don't know that the child has got a Rho transfer, because it is not only lupus, it is also Sjogren's, where we have a lot of Rho antibodies. So when we have a Sjogren's mother, not just lupus, so it's basically the problem of the Rho antibody. The anti-Rho antibody is the one which gets transplacentally transferred and then causes this maternal, the fetal bradycardia or the heart blocks. So if your mother is known case of lupus, then or a Sjogren's, having a high titer of Rho antibody, then you are monitoring actively for a heart block. But when you are not knowing that, and then a child is presented to you with a fetal bradycardia or a neonatal bradycardia, then you would go back and evaluate the baby and the mother. Apart from this, the neonate born to a mother with anti-Rho antibodies can also have thrombocytopenia, can also have elevated liver enzymes, and can also have the rash. And the neonatal lupus rash is pretty classical. It's predominantly on the face. It's around the eyes. So they are also called as raccoon eyes. So like a raccoon, the eyes are, the rash sometimes clusters over there. The rash, the thrombocytopenia, and the transaminitis are self-limiting. So we don't need to treat that. What we need to treat is the bradycardia. What we need to treat is the AV block. So if we, and there are studies of betamethasone and dexamethasone during pregnancy, when we can give betamethasone. The PRIDE study was there, where you could give betamethasone to the mother and reverse this first degree heart block. Sometimes you can reverse the second degree heart block also if it is detected very early. You've detected it today and you give it. So the second can convert to first, or the first can convert to a normal rhythm also. So that is something which needs to be seen. Now, apart from this, this was a neonatal bradycardia. Now, in autoimmune conditions, there are other associated conditions also where you can get bradycardia, not just in a pediatric patient. So, like how you see viral myocarditis as a cause of bradyarrhythmia, similarly, a myocarditis in a lupus patient can also occur. Or sometimes, so you would remember we had a child with vasculitis of the coronary arteries, and they can also present to us with bradycardia. So sometimes these, and then we had a child with mixed brady and tachyarrhythmias. So this child had bradyarrhythmias, and then we thought that he would require a pacing, but we got away with just IV methyl pred. So sometimes the SA node and the other node abnormalities can occur, especially in lupus. So lupus can give rise to a lot of rhythm abnormalities. Lupus can give rise to vasculitis of the coronary arteries. Lupus can give rise to the also the vasculitis abnormalities can occur as part of Apla syndrome also. So the antiphospholipid antibody syndrome also. Similarly, the mothers with antiphospholipid antibody syndrome can also have the transplacental passage, and then the fetus can also present to you with bradyarrhythmias. So it's not just the Rho antibodies, but the APS syndrome also can sometimes give rise to these problems. So we can broadly classify them under three groups. One is the anti-Rho associated problem of a bradyarrhythmia because of the AV block. The second could be autoimmune myocarditis, which could be as part and parcel of a lupus. And the third could be a vasculitis syndrome, which could be either secondary to lupus or secondary to antiphospholipid antibody syndrome. This is how I would, broadly classify and remember.
Yes. So normally in the fetus, if mother is having lupus, we think of doing anti-Rho, La, ANA, and APLA also, because if you want to find a cause for the heart block.
Yeah. So we should try to look for in the mother as well as the baby. And in the baby, there's no point doing the ANA because the ANA would be of the mother only. So, but we could look at the Rho antibody of the baby, and then because then it would help us to as a baseline if we do it, and then gradually we can follow it up because then the titers would keep decreasing. So typically the titers would decrease by 6 to 9 months of the circulating antibody.
Thank you, Dr. Manjari.
Yes, somebody has raised the hand and has a question.
Yes.
Yes, there is a question that Mobitz type 1 block, if seen by a pediatrician, should it be sent to cardiologist for pre-op fitness?
Yeah, actually, because as I said, Mobitz type 1 usually a benign rhythm. It is just like prolongation of PR interval and a block. It may not require, if you're very confident it's Mobitz type 1 only and not 2 or complete heart block, may not require really a cardiologist opinion. You can take that call because it's supposed to be a benign rhythm, and see for underlying any causes like either electrolyte imbalances or metabolic causes which can cause that.
I think I just would want to, add another point that in Mobitz type 1, just for pediatricians who may not be very comfortable diagnosing, in Mobitz type 1, the RR changes, the RR interval duration changes. Whereas in Mobitz type 2, or even complete heart block, or even type 1, which is prolonged PR interval only, grade 1, RR doesn't change. So it's the only arrhythmia, and of course, besides sinus arrhythmia, where the RR will shorten actually. As the PR prolongs, RR actually shortens. So it is not so difficult to diagnose.
Yes, yeah. RR actually shortens in Mobitz type 1, as Dr. Anita said. So if you're very comfortable that you are sure that you are dealing with Mobitz type 1, you may not require other consultation. Now, how do we investigate this? And the commonest thing is what we do, it is ambulatory ECG Holter monitoring, and it can be extended from 48 hours to 7 days. And so, some of the devices, you can keep it for 21 days as well. So it continuously monitoring your heart rate during every activity, when you are sleeping, when you are climbing stairs, you are running, jumping, anytime. It's a non-invasive test. It doesn't affect patients' daily routine. It's riskless and painless. And now if you see the newer devices, they're this small for the children. They're really very small. And you can keep it for 48, 72 hours. Usually we prefer to keep it for 72 hours. And they're so small. And after 72 hours, you can give it for assessment. And then I show you one report. Now, this was a child who came with a heart rate of, as you said, around 50. And it was very unusual for a child who came with a heart rate of 50. She had just a history of surgical closure of VSD in infancy. Otherwise, she was absolutely normal going to school. And then it was little worrying because with a history of VSD closure, whether this heart rate is abnormal or normal. And then we did a Holter. You see this heart rate at some time it was going to 40. At some time, it was going to 140, 150. And this is the advantage of putting them on Holter test. And then we saw at what time this heart rate was becoming so low. Still, you see, this is a sinus rhythm. This is not abnormal. And this was during deep sleep at 2 a.m. in the morning. So this can be considered as normal. Somebody has a serious, though it is a significant bradycardia, but it was during deep sleep. And on the other side, when the child was playing or going to school, the heart rate was going back to around 120, 130. So this is a way we try to assess, though it is a bradycardia, it happened during deep sleep. So you don't need to bother too much. And on the other side, there was a response to exercise. When the child was running, the heart rate came back to normal, which we expect during exercise. So this is an important advantage of keeping the child on holter for some period of time. Even your Apple Watch does the same thing actually. You can just monitor your heart rate during all the activities. And when many parents, when this kind of a thing happens, just take a quick ECG and send to us for review. It gives us some idea whether it is abnormal or normal. So when it is to be used, if you have to correlate symptoms with heart rhythm, now here we have a 50 heart rate with a normal child. So whether we are treating the rhythm or we are treating the symptoms, it's very important to correlate. You evaluate the severity and frequency of bradyarrhythmias, at what time it happens. Does it happen during exercise? Then it's really bothering. If you have a heart rate of 50 when the child is running, it's bothering. See what is the response to exercise. One of the things, like when they are running or playing, if the heart rate increases, you are less worried because you know there is a normal response to exercise. Assess the response to treatment. Suppose the child is hypothyroid and you are really treating the hypothyroid part of it, and see what happens to the heart rate after you treat the child. Identify high-risk patients for certain cardiac arrest. Diagnose specific type of arrhythmias, and it's important thing for a syncope evaluation. Suppose the child has repeated syncope, but your heart rate is otherwise normal, and you don't know exactly what happens during syncope because by the time the children come to us, they are absolutely normal. So this will evaluate whether how to correlate the symptoms with heart rhythm. The next thing is echocardiography. In fact, by and large, we may not do echocardiography if you feel clinically child is normal. Only thing, suppose you have to rule out you have a murmur or you have a sign, the oxygen saturation is less, and you have to rule out complex heart defects. Post-operative heart blocks. If you have ventricular dilatation, because as I said in athletes, if your heart rate is very low, usually they have progressive ventricular dilatation and ventricular dysfunction. We need to assess that. Is there AV wall regurgitation? The another thing is stress test. It's basically to see what is the response to exercise. And the same information actually we get on Holter. So there is no specific thing we do see in stress test. And how is the sinus node response to adrenergic drive, and see whether there is a chronotropic incompetence, because somebody doesn't attain the heart rate which is expected for that particular exercise, which we need to see, and that is the importance of stress test. One thing, whether it's been asked whether a head-up tilt test is required. It's usually used for evaluation for syncope, and we need to see how the body regulates the heart rate and BP response when they change the posture. Again, it is to assess the susceptibility of individual to vasovagal reactions in a controlled atmosphere. Determine whether the symptoms during the study corresponds to the symptoms during the spontaneous event. So somebody has a syncope, we need to see whether we really change the postures, what happens to the sympathetic stimulation when we change the position from lying down to the standing or a sitting position. Obtain patient actually confidence that the physician is witnessing that your change in the posture is not changing your heart rate. And sometimes just by changing the posture, the child has syncope, and we evaluate bradycardia. The patient may learn and recognize the symptoms and take appropriate action. So you see what we try to do. The patient is sleeping. We try to elevate them to 45, 60, 90 degrees and try to monitor the heart rate and blood pressure. And this is how the head-up tilt test is done. Most of the time, we may not require to do it. And now, as I said, because of many other things which are available, like even an Apple Watch, only thing this is in a controlled atmosphere. So we exactly know what happens when we try to change the child from the supine to different positions. Whether they need invasive testing, somebody has bradycardia for a long period of time. So sometimes we do pharmacological testing, like inject atropine, isoprenaline, see what is the response to the heart rate. Very rarely, just for bradycardia, we advise invasive electrophysiology testing. And this is mainly to see the sinus node recovery time, sinoatrial conduction time, and AV node conduction time. But for bradycardia, very rarely we advise for invasive testing. So as far as the management is concerned for a child with a long sustained bradycardia, usually the prognosis depend upon the underlying cause. As I said, just sinus bradycardia does not need treatment, and it may not have any really underlying cardiac cause. So consider whether it is secondary, what are the underlying other metabolic or electrolyte imbalances, and see whether you can correlate the symptoms with the heart rate. And the commonest cause, as I said, is again a sinus bradycardia. And management according to the hemodynamic consequences. So bradycardia without hemodynamic consequence, see for symptoms, echocardiographic function, is there a risk for progression of a high grade blocks? They may have to be seen periodically to see all these things, risk of pause dependent tachycardia. We have to determine the follow-up frequency and any other factors for intervention which is required. And bradycardia with hemodynamic consequences, I think you know better, you have to have pulse guidelines. And bradycardia associated with cardiopulmonary compromise, again, if there are no support with ABC's oxygen observe, consider expert consideration. And if there is a cardiopulmonary compromise, then again, you have the CPR guidelines and pulse guidelines. So what are the pacing guidelines for a child who has significant bradycardia? So usually, as I said, sinus bradycardia, Mobitz type, second degree AB blocks, Mobitz type 1 may not require any treatment. Advanced a second or third degree AB block associated with symptomatic bradycardias, dysfunction, low cardiac output. If sometimes we do have patients with severe sinus bradycardias or sinus node dysfunction, what we call it is a sick sinus syndrome. Sometimes they have significant bradycardia, sometimes they have a sinus tachycardia, but they have symptoms correlation for age inappropriate bradycardias. Many times we do see post-operative complete heart blocks. We usually wait for maybe sometimes up to 2 weeks to see whether the child comes back to sinus rhythm. Otherwise, they should be considered for pacemaker. Congenital third degree AV blocks with wide QRS escape rhythm, that many times we see with the mothers of lupus because they have something kind of a myocarditis because the conduction system incomplete is affected. So third degree heart block in a neonate with wide QRS complex, and this many times we do see them because our fetal echoes, we can just pick them up as a complete heart block. They get delivered in a tertiary cardiac center, and if they have a heart rate with less than 50, cardiomegaly, no response to when they are crying or some medication, usually they are considered for a pacemaker. And congenital third degree heart block with a heart rate of less than 55, ventricular rate of 70, doesn't go increase with exercise, we have to consider them for pacemaker implantation. So high degree AV block, clearest indication for management of bradycardia is high degree AV blocks considered for pacemaker implantation. In young newborns and very young patients, I'll just show you how the pacemakers have been put. Usually we put epicardial pacemakers, not the endocardial pacemakers. Myocarditis can include high degree AV block or complete AV block, require early pacing. And again, management depends upon patient's age, whether the conduction system recurs after the surgery, and what is a QRS complex, whether it is a narrow QRS complex or a broad QRS complex. So these are the pacemakers. Actually, pacemaker has this battery and there is a lead. The lead goes to the patient's endocardium. So usually these are the pacemakers where we use an endocardial approach, and usually this endocardial approach like this, we go through the subclavian vein, go inside the heart, and this lead is in the right ventricle. And usually this is endocardial approach is used in a bigger children who are more than 15 kgs because the veins are small. And in smaller babies, we put the pacemaker by surgery directly on the epicardium. So this is the X-ray of the child, how the pacemaker is seen. So in general, sinus bradycardia is rarely due to primary cardiac pathology and may not require active management. Always a reversible causes should be sought and addressed. Address clinical and hemodynamic stability. Junctional rhythm or escape rhythm suggests sinus node dysfunction, but should be treated like a sinus bradycardia. First degree, second degree Mobitz type 1 block, usually not symptomatic and may not need treatment. Second degree AV block, which is Mobitz type 2. Third degree AV blocks, just symptomatic, usually require pacemaker. So thank you. If there are any discussion points, Neeraj, I'm happy.
Yes, ma'am. Yes. So we know we have in the panel pediatricians also. Dr. Gokhale sir, your opinion about this bradycardia, any questions from your side? What troubles you face in your practice about bradycardia and heart blocks? Any comments?
Yeah, yes, it was a really a wonderful talk, and in fact a revision for all of us, because these are the situations we have faced in the past. Dr. Kulkarni has been known to us for her work, because some of the patients very early in my career when I was a young pediatrician, we used to send to her in Madras, Chennai, MMM,
I know.
and she has been following up those patients right from there, and they are doing all fine. And I'm very happy that she's taking care of them. One important point was that we were always told that bradyarrhythmias are the ones which you have to be worried about. The lecture was really exhaustive, and she has not really left too many points as doubts remaining in the minds of people. But many times, what I want to ask is that there are various situations of infectious disease where there is a low count, especially in dengue and other type of this infectious diseases, where the heart rate really dips, and it's a real panic situation, because at bedside the parents are also watching heart rates dip to as low as 35 or 40 in the night time. We all get reassured that nothing needs to be done. That is one situation which I would ask Dr. Snehal whether she has had any situations where this can cause problems. And the second is the one is that how to monitor for sudden shifts causing bradyarrhythmias in the ICU setup.
See, I think the first thing is question is here as far as the dengue is concerned is very important, because we see patients with dengue myocarditis who have myocardial dysfunction. And I feel that just don't panic for low cardiac output till the time your peripheral perfusion is good. I don't think we need to do anything, because they are usually self-limiting, and as the improvement in the disease process happens, usually all these things recover on this own. But sometimes really you have a very low heart rate and you feel they are really bothering as far as your cardiac output and the peripheral perfusion is concerned. We may have to consider a temporary pacemaker in a bigger child. But most of the time, as the baby improves in your process of dengue treatment, usually you don't need to do anything, just because they may have a GI upset, vomitings, your hypokalemia can be a problem. Please see to it that that is corrected.
Dr. Smita Mishra ma'am is also there. Ma'am, your comments and questions about this class today.
That was a wonderful presentation, ma'am. Congratulations. And actually all the important point in very simple way has been addressed. But my sometimes I feel, and I just want to learn from you, is like somebody is presenting with the heart rate of 55, and what will be the difference in approach for a person who is having a sinus bradycardia where PQRS relationship is maintained, or in a case where there is a first degree heart block, or there is a 2:1 AV block, Movis type 2, or the complete heart block with good high this thing and good heart rate and little bit chronotropy also. So what will be our risk stratification on those conditions?
Yeah, actually, good question, Smita. But as I said, like if it is a sinus bradycardia or a first degree heart block with a rate of 50 or 60, I showed you one example how we did a Holter monitoring, and we know that if there is a response to exercise, narrow QRS complexes, and the heart rate is low only during sleep or some other situation, I don't think we need to worry for that. The sinus bradycardia, first degree heart block, junctional rhythm don't need to be worrying unless you rule out the underlying causes. But of course, if you have a third degree heart block, Mobitz type 2 second degree heart block, and there are specific guidelines, if your heart rate is less than 50, doesn't have a response to exercise, even without symptoms also, if the heart rate and there is a cardiomegaly, we'll go for a pacemaker implantation. And after surgery, even the heart rate, any open heart surgery, the heart rate is less than 70. It doesn't have a response to exercise. We don't need to wait because we don't know when the child will land up in a syncope. So sometimes we just may have even a backup pacemaker, because at what time they will go to a rate of 30 or 40, we do not know, especially after exercise. We need to consider them for a pacemaker implant. But
Thank you
don't
so
worry
much.
for a first degree heart block or a Mobitz type 1 second degree heart block.
Thank you, ma'am. And only one question more. For the complete heart block with good heart rate in the newborn and further in the infancy, should we go for Holter monitoring, and how often we must do it? And even echo, how often we must do it?
I think echo is just for initial assessment that you are ruling out any significant heart problem. The heart function is normal. There is no AV valve regurgitation and no ventricular dilatation. That is just a first screening for bradycardia in a newborn. But a significant bradycardia in children is really a worrying thing. And Holter monitoring, I don't think it is possible to, it may be possible. Sometimes it's very difficult to keep the Holter monitor on a newborn or small infants for a long period of time. There we have to take a call there itself. What is the cause? And usually, as I said, sinus, if it is just a sinus bradycardia, but it is a 50 heart rate in newborn is a really a worrying thing. We need to rule out the underlying causes. And if there is nothing, we may have to consider, but it's very rare to have a severe sinus bradycardia in a child without any secondary.
Thank you so much, ma'am. It was a wonderful presentation and good explanation. Yeah.
Saxena ma'am, there are two questions here.
Yeah. So
How
let
to
me
do
just
pacing in a newborn? Yes, ma'am. Please.
I would answer those questions a little later. I just wanted to continue the discussion that we had. One is about the pacemaker that Smita asked about. I think, as Dr. Snehal said, sinus bradycardia, type 1, Mobitz type 1, one need not worry. But yes, if it is complete heart block or Mobitz type 2, yes, pacemaker may be indicated in a given case. And heart rate is a good indicator, but not the only indicator. If it is less than 50, 55 without structural heart disease, perhaps you can follow them up. But if it is 55, 60 with the structural heart disease, we would rather give them a pacemaker. I have seen in my practice over the years, our threshold for giving an epicardial pacemaker has been going down, simply because we have much smaller pacemakers now. We have much safer procedures that are being done. And therefore, these days, complete heart block without structural heart disease, often these children are getting a pacemaker, unlike earlier where we used to follow them up. And when you give them a pacemaker, I think there is a definite improvement in their quality of life that they complain. Obviously, they never knew what quality of life was before the pacemaker was given. So I think overall, our threshold for giving a pacemaker has gone down significantly over the years. And I would say that anybody with a heart rate of less than 55, with a broader QRS, with a prolonged QT, let's not hesitate in giving that patient a pacemaker, be it epicardial, and in bigger children, it can be endocardial. The second thing I wanted to highlight to Dr. Gokhale's question about sinus bradycardia in the setting of, let's say, dengue or any other, as long as we know it is sinus tachycardia, one need not worry. And I think for the sake of the, just checking, you could even try giving them isoprenaline infusion. We do that very often, and most of these sinus bradycardias will respond to isoprenaline infusions and will increase the rate rather than giving them a temporary pacemaker, because that really becomes an issue. And in a pediatric practice, it may not be always possible to give them a temporary pacemaker. And the third point I wanted to highlight was about sinus arrhythmia, something that I think a lot of referrals come to cardiologists from the periphery for simple sinus arrhythmia. Again, as Dr. Snehal has very clearly said, as long as you have a P followed by a QRS with almost a normal PR interval, one need not worry about sinus arrhythmia at all. It's a very common normal finding in children, especially younger children. Then I think you wanted me to take up this question, how to do pacing. Yes, I think as far as temporary pacing is concerned, that's really quite tough in neonates. And many a times when we thought that patient requires a pacemaker, we would rather give them a direct epicardial permanent pacemaker rather than doing a temporary. But I have done temporary pacemaker through an umbilical vein also. So you can use that route if you are really stuck. As far as levocarnitine, I don't know. I have very little faith on levocarnitine in myocarditis, but I'm sure pediatricians can perhaps throw more light on it.
I think carnitine deficiency has many other things. They have multiple episodes of hypoglycemia and just carnitine deficiency. And sometimes we used to treat the in patients with dilated cardiomyopathy or myocarditis, but I really do not know whether it has a specific role.
I want to comment. I want to share my experience with one patient, and probably it's very important for the pediatrician. Like one patient for the 2 years presenting on the ACT, anti-convulsive therapy, presented to us, and subsequently we diagnosed that it was a severe bradycardia because of complete heart block. But the thing was very interesting when we were taking this child for the temporary pacemaker, looking at the very low heart rate. This patient went into ventricular arrhythmia, ventricular tachycardia. And it is very important that sometimes the bradycardia dependent, what Dr. Snehal actually touched this word, tachycardia, and it was that. So, and it was so difficult to resuscitate at that time, that baby. So heart rate is very important even for a child coming with the convulsions. That is.
And I would just like to add on to Smita that QTC interval is often elevated in these patients who come with or who have ventricular tachyarrhythmias dependent on bradycardia.
And some of your anti-epileptic drugs also, Smita, they prolong the QT intervals, and they also need to be, every time need to be looked carefully for that.
Retrospectively, regarding the L-carnitine use, what we have learned over a period of time is that if there is a persistent lactatemia in a child with myocardial dysfunction due to various causes, we are more keen to use the carnitine. Recently, we had a child who had a persist lactate all the time without any known cause. Even the myocardial function till the very end remained the same. On genetic, we later on found out that it was a carnitine deficiency. So that is one lesson. In 2-3 cases, we learned that if the lactate is persistent with all the efforts going on, maybe that is the only time we'll use L-carnitine.
There's one more question here in the question answer box. Can a patient of sinus bradycardia have syncope or cardiac arrest during or after exercise in the OPD evaluation? Basically, this is trying to find out like if can be sinus bradycardia and can we have the exercise.
Usually it's not, but as I said, if you want to be, we have to be more sure, then we have the 72 hours Holter monitoring and let the child do whatever the normal activity the child is doing the whole day, which will give us a objective evidence of whether the symptoms are related to the bradycardia.
Yes, I commonly do when the OPD patient comes with bradycardia and the
I just
ECG.
make them run a little bit here.
Yeah, in the OPD only you ask them to sit up and down for 5 times, what is that.
And then usually we come to know about it.
Pankaj sir, what is the plan? Can we conclude the session?
I think, Neeraj, it's a very good initiative. And as I told you in the beginning itself, I think you compile all these things for the, in a workflow format for all the pediatricians guideline, get all the lectures together, which I suggested you.
Yes, ma'am. We're doing it, ma'am. We're doing it.
Yeah, it will be very helpful for them because these are the common problems. All these lectures are really very good.
And all our lectures are by the experts, so they are really
You can compile them together as a practicing guidelines.
Yes. We'll do this, ma'am. With all of you around, we'll do it. If someone is interested, आप interested भी हैं, तो we'll do it, ma'am. We'll do it.
Yes. So
thank you for the excellent session, ma'am. Concluding remarks from Dr. Saxena, ma'am. Concluding remarks from Saxena, ma'am, and then we can.
I think first of all, great session. I'm sure all of them are great sessions and a great initiative by Dr. Neeraj. I think as a part of our society, which is not IAP, which is Pediatric Cardiac Society of India, we've always stressed the need for pediatricians to be, be in the loop of whatever we do. And I'm very happy that you are taking it forward. And I'm, more power to you because now you've taken as the secretary of IAP. So I think you've really shown what all you are capable of doing, and I'm sure you'll go ahead. Thank you, Snehal, for that wonderful insight, keeping it very simple and very, very relevant and pertinent to the context that we are dealing with today. And thanks to all the co-panelists that I had, and I think very good interaction from all of them. And I'm sure it would have helped all the participants as well as the panelists, myself, and all of us here, because I think these sessions are really very refreshing for all of us. So thanks to everyone, and the special thanks to Dr. Neeraj.
Thank you, ma'am. Thank you. We can conclude the session. Thank you.
This was initiative by IAP Delhi State. I would like to felicitate because master classes in the different subspecialty, Dr. Pankaj and Dr. Meena, Dr. Namita, they have taken, and Dr. Dinesh Goyal. So they have taken a good initiative, and they are going on month by month, I think. So Dr. Neeraj has led this initiative, and as well as now his strong shoulders, he is taking the National Pediatric and Fetal Cardiology Forum, which I was part of some times ago. So I am very proud of you, Dr. Neeraj, and Dr. Pankaj, Dr. Meena, everyone.
Goyal sir is there. Yeah.
Yeah, I would like to say a few words, and it's initiative by IIP Delhi, and I must congratulate Dr. Neeraj sir and all panelists for today's session. And it's a wonderful session. I just learning lots of things from you. And with this, thank you so much from IIP Delhi.